So rehab sometimes falls short because, well, for a few reasons. Number one, when people are rehabbing, many times they're just looking at strengthening something that feels super weak. But many times there's a reason that muscle got to be weak or injured, or the joint got to be injured in the first place. So we go one level beyond strengthening the local pain area and problem. It's very common for people to have a functional weakness adjacent to the point of pain. If all you're doing is rehabbing the point of pain, it's going to be a miss. Additionally, I would say that the progressions of how we take people through rehab is a really big differentiator for us. We find oftentimes in typical physical therapy, people are progressed forward, whether or not they're ready. People are kept on a schedule, and we're looking more at how the patient is keeping up with our functional benchmarks versus just pushing them through the process and getting them out in a certain period of time. For example, we're not going to move you faster until you're really good at moving slowly in the right pattern. After an injury, after a surgery, anything like that.
When it comes to surgery, I think we're different because we're very concerned with fascia and how that's functioning all the time, but especially with surgery because fascia is where scar tissue is held. And if you're not addressing your scar tissue and how your fascia is moving post-surgery, that's going to stick with you and it's going to cause other problems down the road. In the office, we'll do fascial work and we'll make sure that the surgical site is not causing inhibition of certain muscles in the surrounding area.
So post-surgically, patients in our experience have a couple different problems. Number one, they have a long-standing issue that caused a breakdown, either a tear of a tendon or a breakdown of a joint. There's already a problem before they have surgery. Then the surgery is additional trauma that they're deciding to incur in order to fix the issue, the structural issue, which was long-standing. But then you also have to fix the surgical trauma. Fascia is responsible for up to 50% of our power when we move, and your fascial slings cover your whole body. It's how one muscle is connected to another, even though anatomically the attachment is not exactly connected, but it's the way your finger flexors, for example, and your forearm flexors and your biceps are all integrated into one. So if you have an incision or an injury in the fascia in any part of that chain, it will change the way the whole chain functions. So we're very concerned with the whole chain functioning well. And then locally, when there's scar tissue, that area has to learn to slide and glide again really efficiently. Otherwise, the nervous system will read it as a tension malfunction in the fascia, and it will change the resting tone of the area, which means it's either going to increase or decrease the tone and actually inhibit the muscle. So that's a problem when you're trying to rehab a post-surgical patient. We have to address the fascia, number one, get the muscle firing well every time without any major pain. Then we need to fix the issue that caused the problem in the first place. The surgical issue fixed the structure, but then we have to come in and fix the function afterwards. So we're going to be looking at muscles that have been inhibited for a very long period of time. Almost every hip replacement patient or ACL replacement patient that we have, they have an inhibition long-standing around the joint that caused their breakdown. So then after we address the initial post-surgical issues, the fascial issues, we have to address the long-standing functional cause of the injury in the first place.